Dear Chairman, thank you for the invitation to present at EBC 2021 meeting. The title of my presentation is Visually Estimated Resolve Score based on Computed Tomography to Predict Side Branch Occlusion in Percutaneous Bifurcation Intervention. Bifurcation lesions account for 15 to 20% of all percutaneous coronary interventions, and side branch occlusion remains major procedural complication. To predict the probability of side branch occlusion after main vessel stenting, Resolve score was designed for evaluation of invasive coronary angiograms. Notably, this simple tool showed good results with both quantitative measurements as well as visual estimation. Originally, score consists of 6 different variables, and 5 out of those 6, with only exception of TIMI flow grade, can be derived from pre-procedural computed tomography angiography, a modality that is currently emerging as an attractive method for non-invasive assessment of coronary arteries before attempted PCI. Our group showed previously that quantitative CTA resolved score performs as good as gold standard, being angiographic visual resolve score, whereas the quantitative coronary analysis provides an objective determination of severity and extent of coronary artery disease. It might be time-consuming and thus less frequently used in real-life clinical practice. To simplify and expand the application of non-invasive CTA for predicting side branch occlusion, we employ the visual estimation of each constituent element of the original quantitative CTA resolve score. Test ground for our study was a sample of 400 bifurcation lesions in 363 patients, in whom a total of 28 side branch occlusions were noted. The overall diagnostic capability of CTA-derived resolve score was significantly higher as compared with its quantitative counterpart. The results of the reclassification analysis revealed that the CTA-derived visual resolve score correctly predicted more lesions with side branch occlusion into the highest risk category as compared with the quantitative CTA resolve score, thereby suggesting improved discrimination among lesions at greater risk of side branch compromise. We believe that this observation might rely on numerically higher area under the curve of CTA-derived visual resolved score for 3 out of 4 different constituent elements of the scores. Moreover, our data confirmed ability of CTA-derived visual resolve score to stratify lesions into high-risk group and non-high-risk group of side branch occlusion, specifically by using the cutoff value of 17 point, which was defined as the lowest score in quartile 4 for discrimination between high-risk group and non-high-risk group. The incidence of side branch occlusion was significantly higher in the high-risk group, that being nearly 19%, than in the non-high-risk group, that being cumulatively 3.8%. Also, the discriminatory performance of CTA-derived visual score resolve score was equal to the quantitative CTA-derived resolve score, as confirmed by comparable rates of side branch occlusion within high-risk groups. Interestingly and consistently with prior angiographic studies, the lowest score in quartile 4 for CTA-derived visual score, being 17 points, was higher than that of its quantitative counterpart, being 12 points. That emphasizes the overestimation of visual assessment when compared with quantitative CTA analysis. This aspect is underscored by the agreement between visual and quantitative CTA analysis. While it was excellent for bifurcation angle and moderate for diameter stenosis of side branch, it was only fair for diameter ratio between main vessel and side branch, and poor for diameter stenosis of bifurcation core. Noteworthy, the agreement between the constituent elements of CTA-derived scores was comparable to prior comparison of visual estimated versus quantitative and geography-based resolve score, where kappa ranged between 0.2 up to 0.4, thereby suggesting certain level of variability intrinsic to each imaging modality. Interestingly, we noted numerically higher values of all visual constituent elements of the scores as compared with their quantitative counterparts, along with reclassification of the quantitative CTA-derived resolve score into higher categories based on visual assessment. As such, the proposed CTA-derived visual resolve score might be particularly useful in identification of larger number of lesions at increased risk of side branch occlusion after initial main vessel stenting, and might be used to determine optimal preemptive measures depending on the importance of the side branch. This could include, for example, protection of the side branch with a body wire. It can include application of two-stent techniques of the procedure, or even deferring PCI and referring specific patients into the surgery. Nonetheless, further studies are warranted to find specific CTA predictors of side branch occlusion. Thank you for your attention.